Alert Medic 1 respond. Box area 19
You're listening to the Alert Medic 1 podcast, the premier emergency medical services podcast with your hosts Mustafa Siddiq and Ken Sanner.
Welcome back to the Alert Medic 1 podcast. My name is Mustafa Siddiq. With me, I have Brian and Ken.
How's it going?
Hello.
So today we're going to be talking about LVADs. I'm really excited to have Dr. Asa Margolis with us today. Dr. Margolis began his career in medicine as a pre-hospital provider over a decade ago. He's board certified in EMS after completing the EMS fellowship at the Johns Hopkins University School of Medicine, where he also completed his residency and was a chief resident. He is currently an assistant professor of emergency medicine at Johns Hopkins and program director of the Emergency Medical Services Fellowship. Dr. Margolis is the medical director of the Johns Hopkins Lifeline Critical Care Transport Program and associate medical director of the Howard County Department of Fire and Rescue Services. He also continues to work closely with several local, state, and federal agencies as a medical officer within the Center for Law Enforcement Medicine at Johns Hopkins. I did not know that last part. That's pretty cool. Welcome, sir.
Thank you very much for having me. It's great to be here.
At some point, I would like to, at the end of the episode, just briefly talk about that EMS fellowship, because I think that's something that a lot of paramedics don't know about.
Absolutely.
We're going to be doing a larger episode on that as well. But for now, LVADs. So I think in general, when an EMS clinician hears the word LVAD, they kind of cringe a little bit because a bunch of uncertainty is usually associated with patients that have LVADs. So, but before we get to the actual LVAD part, I want to talk a little bit about normal heart anatomy and physiology and what can go wrong, which would then cause a patient to need an LVAD. So briefly, I think we all understand, the heart functions as a pump. As organisms grow larger, they become multicellular and they need an efficient way to circulate nutrients, oxygen, and also get bodily waste out, right? So the heart acts as that pump. It goes without saying, we know the basics of heart failure. But Doc, if you could talk to a little bit about what can go wrong, which would cause a patient to need an LVAD.
Yeah, great. So, there are a few important terms to at least have a good understanding of when we discuss heart failure and heart function itself. So one is cardiac output. And, cardiac output is the total volume of blood that is pumped out by the heart per minute. Okay, and it's really the product of the blood pumped by each heartbeat or contraction, which is known as your stroke volume, and the number of heartbeats or your heart rate. When one of these variables becomes compromised, it can lead to heart failure in a patient. Heart failure is interesting in that it can be categorized in a number of different ways. I think for simplicity's sake, and for the sake of this discussion, we'll be referring to heart failure in terms of heart failure with preserved EF or ejection fraction and heart failure with a reduced EF or ejection fraction. It's just a little bit easier when discussing some further points to have it, that framework in mind. The heart failure, the incidence and prevalence of heart failure is definitely increasing, due in part to the success of cardiologists being able to, salvage, save patients that have had significant MIs or myocardial infarctions. And with the aging population, more and more people we're seeing with heart failure. Approximately 50% of the heart failure population has a reduced ejection fraction. And then a smaller subset of this population, probably about 10% or so, rough estimate, would fall under the advanced heart failure symptoms as classified by the New York Heart Association. And that's how we classify functional heart failure. And these are the individuals, particularly those class 3B and class 4 heart failure, who end up getting a ventricular assist device. Again, due to history of an MI, due to myocarditis, right, an infection of the heart, due to substance use throughout their life, alcohol, cocaine, all of those things can cause long-standing heart failure.
With that, I just wanted to, could you explain for our listeners ejection fraction real quick, just that concept, what that means?
Yeah, so, I think the best way to think about it is how strong the heart is able to pump blood forward. And that ultimately is going to meet the needs of the rest of the body, in particular, the rest of the organs that the heart supplies blood for. Because if one's ejection fraction is poor, you don't have good forward flow out of the left side of your heart, and your organs, liver, kidney, etc., are not seeing normal blood flow. And that ultimately leads to failure of those organs.
Can you just kind of describe what a normal ejection fraction is? I know it's measured in percent, and at what point it becomes so significant that we might need to think about something like an LVAD.
Yeah, great question. So typically when we refer to a normal ejection fraction, we typically use a number of 55%, sometimes 60%. But when we're talking about need for an LVAD or a VAD placement, we're typically talking about very poor ejection fraction, less than 25%. But, it's also important to know that ejection fraction, or in this sense, poor ejection fraction being less than 25%, is sort of one criteria for a patient who would otherwise need an LVAD. In addition to having a poor ejection fraction, these patients, generally speaking, have failed to respond to optimal medical management. They have that poor ejection fraction, and they have a significant functional limitation in terms of what they're able to do.
So let's transition to the actual device. So could you briefly discuss what LVAD or VADs and LVADs specifically, what they actually are, how they function, and some different types and how they've evolved as the technology has evolved?
Sure. So now when we're talking about LVADs, the most common long-term devices that we're seeing out there are the HeartMate 2, the HeartMate 3, and the HeartWare HVAD. These are all known as continuous flow LVADs, whereas earlier models were designed to mimic the human heart by producing a pulsatile flow in parallel with the patient's heart. These newer devices, which are smaller, more durable, provide continuous flow. So these, these continuous flow devices have an impeller or a rotating motor that spins, and that is what is comparable to that initial generation pulsatile device. So this spinning motor or impeller works in parallel, essentially, with the native left ventricle. And that's a really important concept and an important thing to distinguish from the initial devices that were pulsatile, and that now we really lose systolic and diastolic flow, and thus generally pulsatility. Although for someone to maintain pulsatility has to really do with what their native heart function is as well. But certainly with the loss of systolic and diastolic flow due to the continuous nature of this motor, you're no longer able to measure a blood pressure by auscultation as we were otherwise taught. And I think that's really important for our EMS clinicians to remember. So while we're also typically used to putting the automated cuff on a patient now, typically we would take a manual one and we'd listen for essentially systolic and diastolic flow. Well, that you don't have anymore in these continuous flow devices. So instead, it requires a Doppler and a manual cuff in order to obtain a mean arterial pressure, or a MAP. And to do this, you put the blood pressure cuff over where you would typically do over the brachial artery, just above that. And that's where you then, over the brachial artery, you apply the actual Doppler, and you're listening for when a signal returns, and you're recording that as the MAP for the patient.
I think when a lot of people think LVAD, what they're thinking is there's something actually helping the heart pump, that's actually pumping the heart, contracting the heart. But what you're really talking about, and this is a very simplified version, is essentially a fan in the heart that's helping blood flow out of the ventricle.
Yeah, that's correct. And while, there are fine differences between those three common devices that I just mentioned, those three continuous flow devices, all of them function by helping essentially pull blood out of the left ventricle, return it to the aorta, ultimately increasing cardiac output, which is what that term we discussed before, and essentially the amount of blood that gets to the rest of the body, most importantly, the other organs. Because these patients often have renal failure, some element of liver failure, because those organs aren't seeing the normal amount of blood that they should be. And it's very difficult, if a patient happens to be a candidate for a heart transplant, for them to undergo transplant surgery and recover well. Putting this device in, again, if they're a candidate for a transplant, will also allow them to help rehab, get stronger, help their organs improve. So when they go through the actual transplant procedure, they're going to have a better outcome.
Just a quick aside on that. I think how you mentioned we'd be bridging these patients with LVADs to like either while the heart is in the process of healing. How does that actually look in the rehab in that window? Like, how does the rehab, like, what's maybe a timeline, but also how do we make sure that the heart is in an adequate state before we accidentally or prematurely take them off a bad device?
So, these patients are being very, very closely monitored by really a team of nurses, often nurse practitioners or PAs, physicians with advanced heart failure knowledge, cardiologists, right, cardiothoracic surgeons. And essentially they're measuring parameters in terms of the patient's functional ability, as well as lab values. And weights and how well they're doing with fluid and retaining fluid versus keeping fluid off. And all of those points sort of go together to make it so the patient will be optimized for when their opportunity comes up.
So kind of moving on. So now we understand why the LVAD, is utilized. What are some common things that can go wrong that would cause someone to either call 911 or precipitate a transport from, say, a local hospital to a tertiary care center where the specialists for this device are located?
Great. One other thing I actually didn't mention before that I think is important for people to know is there are, two main reasons why people get these devices, right? They all share the fact that they have very poor EFs, functional limitations. They've otherwise failed optimal medical management. But the main categories are either bridge to transplant, right? So these people are a candidate for a heart transplant, and they would have otherwise died while awaiting a heart. But now we have these LVADs to keep them alive and help them rehab. And the other main one is destination therapy, where these patients will otherwise live out the remainder of their life with this device in place. And sometimes they are not candidates for transplant and otherwise destination therapy patients because they have significant comorbidities, which would be life-threatening at the time of at the time of heart transplant placement. So some of these are innate to the patient that otherwise would not make them a good candidate for a transplant. Sort of less common reasons, bridge to recovery. So maybe you put one of these devices in, it helps the myocardium, the heart, unload and recover. You can actually explant the device. And then sometimes, they're put in bridge decision, meaning that, hey, we're not exactly sure yet, let's put it in and we can figure out whether that the patient's going to be a candidate for a transplant. So, you had asked about, what can go wrong with these devices. There are a couple of things that I think our EMS clinicians should have a good handle on. One is pump thrombus or pump thrombosis. And in pump thrombosis, essentially what happens is a clot forms either within one of the cannulas or around the impeller or motor itself. Now, these patients are anticoagulated on Coumadin or warfarin, and they are typically all on some amount of antiplatelet therapy with aspirin, whether that's 81 or 325 milligrams. The idea is to help prevent thrombus formation, but sometimes they occur. And things that we tend to see with thrombus formation is basically a drag on that motor itself, and therefore the motor trying to draw more power in order to maintain flow throughout the heart.
Gotcha. So what are some I guess patient presentation or assessment findings that we would have with those, and what are the treatment options both for our EMS clinicians in the pre-hospital or inter-facility world, and also what's the end game for the physician and the VAD team? Like what are their goals once this occurs?
Typically, your device starts to not work effectively. So they could be complaining of dyspnea, shortness of breath, or chest pressure. They often will tell you that their urine has become dark because they're hemolyzing as the clot is breaking down with the actual motor itself. And then they will probably tell you that their LVAD parameters are changing or not at their baseline. And one of the most important things that EMS clinicians should think about asking is about their baseline numbers, whether they have had any difference in their trends over the past 2 days, for example, whether or not they're having any alarms on their LVAD device. So we tend to see in someone who's having a pump thrombus, power surges. And we tend to be concerned when we see power surges usually greater than 2 watts over their baseline, or certainly when the power is in double-digit numbers. Typically, power for these patients are 4 to 5 to maybe 6 watts. But there shouldn't be power numbers anywhere greater than 9 or 10 for that matter. So again, looking at the LVAD itself, what is the LVAD doing? What are the numbers telling me? How do they compare to baseline? And that's where the patient and family members are really helpful because they know their numbers well. Then assessing the patient. So where is this patient along the heart failure spectrum? Are they decompensated and are they in cardiogenic shock? So are they cold and wet? Or are they warm still and not in shock? And then, as we start to get a little bit further into treatment, once we get to the emergency department, we tend to treat these like other clots that people have. And the first sort of step in management is to heparinize these patients to prevent really further clot formation or progression of the clot. In consultation with the VAD team and cardiothoracics, if the patient is becoming more unstable and the clot is substantial, then there may be discussion regarding thrombolysis, whether that's catheter-directed or systemic thrombolysis. And then if none of that works, ultimately the device would need to be explanted, a new device implanted, but that carries with it very high morbidity and mortality. So until those decisions can be made in conjunction with the rest of the team, it's our job to support this patient hemodynamically because really they're a patient with heart failure. And it just depends where they are along that heart failure spectrum at that moment.
That was one of the light bulb moments for me when I was attending your lecture about LVADs. The fact that these are heart failure patients. I think, like I said before, like we get apprehensive or scared about having a patient with an LVAD, when in reality, when they do have these failures, we still know what to do because we see these patients, right? We in the pre-hospital setting, in the inter-facility setting, we know how to treat heart failure. Kind of transitioning to another adverse event, let's talk a little bit about suction events.
Sure. So again, sort of starting from patient presentation, a typical scenario that a clinician may find themselves facing when they are taking care of a patient with a suction event is that patient could be complaining of lightheadedness, dizziness, general weakness, possibly dyspnea, and they may have had a recent GI illness, so nausea, emesis, diarrhea, and ultimately they have become volume depleted. And in that setting of becoming volume depleted, essentially the pump speed, which is another parameter that is set with the LVAD, is higher than the available circulating volume in the patient. Or in other words, there's very poor left ventricle filling. And in essence, what happens is the inflow cannula will get literally sucked up against the septum. And the patient will start to have these symptoms, but also develop a dysrhythmia. In particular, one that we see is ventricular tachycardia, but ventricular tachycardia with a pulse. Now, the history is important here, because if you're able to sort of break this down and get a history that suggests volume depletion, whether that's due to dehydration from GI losses, volume depletion from overdiuresis, potentially volume depletion from bleeding or hemorrhaging, of which GI bleed is another complication we'll talk about, then it would suggest that the management for these patients is actually giving them volume, which initially is something that blew my mind. Like, are you kidding me? You're telling me to give IV fluids to somebody with such bad heart failure that they need a device to help keep them alive? You're kidding me. But no, in fact, this device allows them to deal with volume. And if their volume is too low, they're going to develop a suction event. Looking at the actual LVAD parameters itself, something that our clinicians may notice is that the speed will be lower than what the patient's typical baseline is. And the machine is actually doing this, slowing itself down. It could do so up to basically a set point where it can't go any lower, but it's trying to slow down the speed to account for that lower amount of volume in the hopes that it can kind of fix its own issue. Concomitant with that is we'll see drops in flow. So flow is essentially, it's an estimate, but it could be thought of as like a marker of cardiac output. This is measured in liters per minute. And normal flow is usually 4 to 5-ish, maybe even 6, but probably more like 4 to 5. And once the flow drops below usually 2.5 liters per minute, and again, it could be adjusted per each individual's LVAD, they'll start to get a low flow alarm. So if these patients are getting low flow alarms or having low speeds or starting to have symptoms of lightheadedness, you go to obtain a map on the patient. The map is 50, which is below the normal map, of which would be 70 to 90. You put them on the monitor, they're having a dysrhythmia, potentially VT. This should all sort of go along with this suction event phenomenon. And while you can give them an antidysrhythmic, it's not contraindicated. And if they're hemodynamically unstable, you can cardiovert these patients. What's actually going to help more is giving them volume, giving them hydration. Other things that may cause also a suction event is basically right heart failure issues, because again, patients with LVADs are very preload dependent. And if it affects the right heart, it's going to affect preload, and that's going to intrinsically make them volume depleted again. Or potentially, an inflow cannula obstruction could also cause decreased circulating volume and therefore this suction event.
I did have one question for you. So I think you've mentioned a couple of times the use of a Doppler to capture a map. In a lot of our pre-hospital setting ambulances, we don't carry Dopplers. However, we might have a patient presentation where they're unresponsive. They might see VTAC on the monitor. You may not get a pulse, but it could potentially be VTAC with a pulse that just we're not capturing. With cardiac activity. What are some and this may not exist, but what are some other tools that we can use in maybe if we don't have Dopplers to maybe see if they are in cardiac arrest versus not in cardiac arrest? Does that question make sense?
Yeah, it's obviously a tough question, tough assessment. Honestly, you're essentially relying on one, whether or not the patient is responsive. Two, are you able to sort of get any sort of respiratory rate on the patient? So is the patient apneic or not? End tidal, right, as a marker of perfusion can also be helpful. We should all make good practice of auscultating over the device to make sure the device itself is running. You should be hearing a hum of the device itself. But short of, again, having the Doppler to obtain a map, which will give you that, all you're really able to rely on is, one, whether the patient is responsive, two, whether or not they're breathing, three, potentially their end tidal, then again, ideally, whether or not you're actually able to obtain this map, because, checking for a pulse, particularly a radial pulse or even a femoral pulse in these patients, may not be super reliable. And patients could be perfusing, meaning not in cardiac arrest, and still not have a palpable radial pulse because they have such poor intrinsic heart failure, and whatever's going on is making them even more hypotensive.
Because what I'm picturing is the patient that has a sugar of 10 that we just don't, because it's so automatic. We go in, they're unresponsive, we check for a pulse, no pulse, we start CPR. And then, 10 to 15 minutes in, we're like, crap, we never checked their sugar, and this patient's an LVAD patient, right? Usually, I understand there, hopefully there's family there. But yeah, go ahead, sorry.
No, you're right. You just want to be very thoughtful, potentially more thoughtful, if that's such a thing, about starting compressions in these patients, because you can for sure dislodge the cannula or device, and obviously that is not a good thing. But if you do an assessment on the patient and determine the patient to be unresponsive, apneic, you can't get a map if you're able to, to Doppler one. The end titles are poor, and the patient, has a dysrhythmia, for example, VFib clearly, but maybe a PEA, and the patient, is in cardiac arrest, and at that point, compressions would be indicated.
Yeah, and I do know that there are a few other complications I wanted to talk about, but I do want to talk about the CPR while we're on the topic. So the answer to can we do compressions on the LVAD patient is then yes, right? From my understanding of your presentation, a lot of times the manufacturer says no. Could you give some reasoning to why that disparity is? I'm assuming it's because of but not bystander CPR, but non-healthcare professional CPR. But if you could discuss that a bit.
Yeah, again, the major concern is that these patients, a lot of them don't have the same elements of perfusion that we're used to checking for. And if we're not aware of that and we're not going and adding sort of more steps to the process, then we could start doing compressions on somebody that is not actually in cardiac arrest, and therefore dislodge or affect the device in some negative way to prevent it from functioning normally, including causing life-threatening hemorrhage, right? If this device is dislodged. And that is not fixable. So, before, we've all obviously done a very good job in EMS and healthcare and educating about early CPR and early chest compressions. But this is one scenario where, it takes a lot more things to sort of put a big picture together to ensure the patient is in fact in cardiac arrest, and not just so profoundly hypotensive and unresponsive, where you're starting compressions, potentially dislodging or affecting the device.
I'm kind of transitioning and building off of the massive hemorrhage scenario that you discussed. I wanted to discuss GI bleeding and what can predispose an LVAD patient to have that severe GI bleeding, and how they present and so forth.
Sure. So I think of GI bleeding as really that quintessential multifactorial problem in VAD patients. As we talked about before, they are anticoagulated with Coumadin. Generally, we see INRs of 2 to 2.5, but sometimes up to 3 in some of these heartware HVAD patients. But again, there's no definite rule of thumb, because it has to balance between how likely the patient is to bleed versus clot. And then the other thing is they have antiplatelet therapy with aspirin. So that's one. Two is they develop an acquired von Willebrand syndrome. And basically that happens because the von Willebrand factor that usually exists as a sort of a large molecule is broken down or cleaved, and therefore poorly binds to platelets within the endothelium of the blood vessels. And that is so important to hemostasis, or to stopping bleeding. And if you develop this acquired von Willebrand syndrome, it's just another sort of hit or strike in the problem. And then the third major issue is that a lot of these patients have AV malformations. And we think this is attributed to basically the decreased pulse pressure that we see with these continuous flow devices. This was really a phenomenon that became a bigger problem with these continuous flow VADs. And this decrease in pulse pressure essentially leads to decreased intestinal mucosal perfusion. And it causes like very fine mucosal ischemia and friability of the vessels. And when a blood vessel becomes friable, it bleeds. So putting this together, you have anticoagulation, antiplatelet therapy, an acquired von Willebrand syndrome preventing normal platelet aggregation, and these small bleeding vessels within the GI system. And again, they would present like somebody who is otherwise on the spectrum of going into shock, but this being hypovolemic from hemorrhagic shock. These patients also present very interesting challenges because you got to be very careful. And where you would typically, for life-threatening bleeding or potential life-threatening bleeding, reverse somebody whose INR is elevated, automatically reversing these patients may cause more of an issue.
Yeah, it'd be very detrimental, potentially. Yeah.
Trying to support them with blood. So keep transfusing them unless they're becoming, very hemodynamically unstable or unable to stop the bleeding. Then, how we reverse them would definitely be in discussion with the VAD team, again, made up of the heart failure physicians and the nurses, nurse practitioners, the PAs, and the cardiothoracic surgeons, because we don't want to, in essence, overcorrect these people and cause them to then thrombose.
Yeah, and that's my question, from my perspective as a pharmacist, do we prefer to go down the route of something like PCC, which may be highly concentrated, but may also overcorrect, versus something like FFP, which gives some volume support to these patients, may correct a little bit? I don't know what you've seen in your practice.
Just real quick, could you say what the FFP, just because a lot of paramedics don't know what that is?
Oh, yeah. So PCC is prothrombin complex concentrate. Essentially, it's a highly concentrated form of some common factors that are within the blood, factors 2, 7, 9, and 10. It's usually in volumes of somewhere between 60 to 120 mLs versus FFP, which is fresh frozen plasma, which contains many of the same factors, some additional factors as well, but can be to reverse patients in the liters.
Yeah, this, to my knowledge, I haven't seen any sort of head-to-head comparisons looking at the two in this patient population that are having GI bleeds. My gut tells me that most will probably go with FFP, knowing that if we either overcorrect with FFP or someone chooses to use PCC, it gives that. Once you get control of the bleeding, and that may require consultation with our GI colleagues as well, the patient would then be put back on heparin because that would allow the patient to continue to be anticoagulated. Obviously, heparin is a lot more easily controlled by turning on and turning off, and then obviously is Coumadin, where the INR has to come down and sometimes doesn't necessarily do so very gracefully. And you would sort of maintain them on heparin until, the bleeding has stopped. We found the source of bleeding, and then we could sort of reinstitute the aspirin and Coumadin for the patient again.
Great. Thank you for that.
Sure.
Transitioning from bleeding to another complication. So obviously with these LVADs, they're not all internal, right? Like not all the pieces are internal. And you have a drive line that goes from the outside of the body to the inside of the body. And anytime there's any sort of opening, you open up the patient to a higher risk of infection. So could you discuss briefly the likelihood, and I'm assuming these patients are going to present, just like any other infectious disease patient up to sepsis, and what are some specific considerations for the LVAD patient when we're treating them?
Yeah, so as you mentioned, you need to have some way to connect the system controller, or essentially the brains of the device, to the actual motor itself. And this is done via a percutaneous, or a line that is known as a drive line, that goes from the controller, enters through the patient's skin, and ultimately connects to the device itself. And as you mentioned, this is a direct conduit from the outside world to the inside world, specifically the patient's bloodstream. So some people actually refer to the drive line as the Achilles heel of the device, in that, you can have trauma affecting it, so it can get pulled or yanked or dislodged, or the thing can become broken, or again, it's a direct conduit for infection. And the main things that we have to tell our patients is that it's all about prevention, and very good care of the drive line itself and the dressing changes that they are taught to do before they leave the hospital, because you don't want to have to start battling a drive line infection, because it really can become a spectrum. So while the drive line itself, and you may get some irritation around the drive line site, this could progress to what we call a pump pocket infection. So now you have an infection that's further into the patient's cavity, and it's like essentially an abscess. Or if it progresses even further, there could be an infection around the actual device itself, which required to be explanted. And as you mentioned, the patient become bacteremic and septic. So when these patients present with sepsis, we absolutely have to consider driveline infections and other elements of that spectrum, including pump pocket infections, bacteremia from this. And, they would present like just any other patient that has sepsis.
When you say a pump pocket infection, are you talking about an infection in the heart itself, or are you talking about something different?
Yeah, so it can actually form a pocket around the motor of the device. So, for example, the HeartMate 2. The HeartMate 2, the actual axial impeller, is implanted subdiaphragmatically, and you have the inflow cannula and the outflow cannulas connected to the heart. So the pump pocket may actually form around the actual motor part, which is subdiaphragmatically, not necessarily in the heart itself. And that is specific to the way the HeartMate 2 sits within the body.
Any specific considerations for antibiotics? Like, are you treating them any differently or anything like that, or are you giving the similar agents as you would a baseline septic patient?
Yeah, so we would treat these patients with broad spectrum antibiotics to start, but also understand that there are some pathogens that we tend to see in these patients that we don't see in our run-of-the-mill, so to speak, septic patients. For example, Candida, which is a type of yeast, and needing to think about that and treating with antifungal medication in addition to antibiotics early on in these patients, and with antibiotics that cover things like Pseudomonas, which we typically would cover for anyway when we use broad spectrum antibiotics.
So the last thing that, in terms of complications, I wanted to discuss was you stressed in your presentation that the timing of complications, whether they be short-term versus long-term. Could we discuss why it's so much more serious or why I should be way more concerned for my LVAD patient when I get them 3 days post-op versus 3 months post-op?
Yeah, as we say, timing is everything, and depending on how far out the patient is from having the device implanted really speaks to what potential complications you can be seeing. So the complications that we had just talked about are typically ones that we think of in a patient who's had a device, for a while, versus what we call immediate or short-term complications. And we typically think of cardiac tamponade in those individuals because they just had surgery literally affecting their heart, right? A device was just implanted within their left ventricle, connecting to their aorta. So that's a unique complication that we need to see early on. So thinking about the clinical presentation of tamponade is important. Aortic deficiency is another complication we tend to see more in the immediate or short-term period, or aortic regurgitation, other name for it. And then arrhythmias. The heart is susceptible to having arrhythmias. We were just sort of in there mucking around with it, and is potentially susceptible to arrhythmias. And of course, while we talked about GI bleeding, additional bleeding potentially from around the site, the surgical site, happens as well. And that's, again, different bleeding in the short-term period than we talk about with GI bleeding, which can happen at any point and typically after the patient has had it implanted for a little while.
One thing I did want to clarify, which we did touch on a little bit, is if you do truly believe that your LVAD patient is in cardiac arrest and you have the evidence to support that, you've got the low end tidal, the apnea, the unresponsiveness, maybe you've got the Doppler, these patients can have CPR done on them, correct? There's a lot of people who think you can't.
That is correct. That is correct.
And that's the one thing I wanted to stress as well, just because I feel like from 10 different people, you could get 10 different answers.
Yeah, and I think what we're all probably getting is everyone's apprehension about doing compressions when the patient doesn't need it. But if the patient needs it as defined by what you just described, then compressions are indicated. In sort of along those lines, but obviously a little bit different, is that you can defibrillate these patients. So if the patient is in VF, ventricular fibrillation, or pulseless VT, you can absolutely defibrillate them. And nothing needs to be changed or done or moved or anything like that. It's just standard defibrillation like you would for anybody else. And if you felt like you needed to cardiovert the patient, synchronize cardiovert the patient, you can do that as well. Again, paying mind to the fact that maybe this patient who's in a ventricular tachycardia with pulses may be in it due to a suction event, and they would benefit more from volume resuscitation than the cardioversion per se.
And along the same lines, Dr. Margolis, transcutaneous pacing, I assume, would be acceptable as well.
That is correct. Transcutaneous pacing. Now, bear in mind that a lot of these patients, probably almost all of these patients, have a pacemaker AICD, and they typically have what we call bi-V or biventricular AICDs because that is along the pathway of trying to optimize them medically before they get to the point where they need an LVAD. So they may have their intrinsic pacer fire or take over. But if it is not and pacing is indicated, yes, you are allowed to pace them.
Real quick, one other thing that, as a neuropharmacist, I've always considered is that there's maybe some slightly higher rates of strokes in these patients. And how would you manage stroke in these patients?
Great question. Yeah, I would definitely put stroke in with the major complications that we see with these individuals. This is always a very difficult topic. Unfortunately, a lot of the strokes that we see in these patients are hemorrhagic strokes as well. And, now you're dealing with somebody who's having a hemorrhagic stroke and they're anticoagulated and they have antiplatelet medications on board. And you're wrestling with, what if I reverse these people? Because now I can cause their divisive thrombose and That's not compatible with life. Ultimately, the messaging to our EMS clinicians is, be aware that stroke is a possibility. Be aware that stroke is a high possibility in these patients. Look for it. If you're concerned about it, transport to a stroke center. And then let us try to figure out, again, working with the LVAD team, the heart failure physicians, the cardiothoracic surgeons, the neurologists, the neurosurgeons, the emergency medicine physicians, how we're going to tackle this very complicated issue.
Yeah, great. Thank you very much.
I can imagine for the physician team that this a stroke in these patients. Like I never thought about it until now. That would be a very complicated presentation.
Yeah, I actually distinctly remember that presentation from my intern year. I think I spent more time like running around in a circle trying to figure out what I was going to do for the patient. This is like very on into my intern year, and I didn't really know anything about LVADs other than they could bleed and they can clot. And this individual had a hemorrhagic stroke, and it was a very sort of difficult case, difficult decision making. And these patients and these cases are certainly not easy.
Are they at increased risk of hemorrhagic stroke because of like the AVMs and stuff like that? Like, is that the theory, or is there another reason?
So they could be at increased risk. So typically, when we think of the AVMs, we're usually thinking of the GI tract, but they could certainly be at increased risk of bleeding, and due to the fact that they're just anticoagulated, and they may be super therapeutic in their anticoagulation as well.
So I guess, Brian, are these the people that are getting their INR checked every week in the clinic, or every couple of weeks, or how's that work?
Generally, I can't speak to how each site does it, but generally these patients are followed very, very closely, typically weekly. And the other consideration is that these patients can't use alternative oral anticoagulants. They just don't have the data to support things like apixaban and Pradaxa at this point. So yeah, they're getting their INR checked pretty frequently.
Yeah, I just had one question kind of along those lines. I know we just said that bleeds are more common than clots, but let's say one of these patients did have a clot in the brain. Would mechanical clot disruption or removal be an option in these comprehensive stroke centers? Is that something I could benefit from, or with all these anticoagulants and everything they're on, is that too dangerous?
So, that would probably be on a case-by-case basis. That's certainly an option. And the more options that we have to treat these complex patients, I think the better we're going to be. Certainly more so than adding systemic TPA to a patient who is on antiplatelet agents, who is anticoagulated, whose INR is somewhere probably above 2. That has a recipe for not great things to happen. So, the more we have to use in terms of treating these patients, I think the better off we're going to be. And again, it's going to be an extensive discussion with our multiple specialists.
That is some really bad luck. If you have a clot after all that anticoagulation, and then oh man, sorry, Brian, you go ahead.
No, I was gonna say it's certainly. If you look at the data, it supports that there are rates of even ischemic strokes in these patients, but it's always so hard. And honestly, anticoagulation is, alteplase is not going to be an effective or appropriate agent, considering most of these patients have INRs well above the contraindication.
Awesome. Thank you so much. Honestly, I think we covered a lot in this episode. To finish out, I wanted to discuss 2 things. So the first one is one of the sentences, and I'll open it up to you guys if you guys have any other last marks. But the one thing that you mentioned in your presentation was no single parameter is a surrogate for the overall clinical picture. That spoke volumes to me, not only with these patients, but with patient assessment in general, especially in someone's dimly lit living room at 2 a.m. when a paramedic may or may not do the most thorough of assessments and jump to one conclusion. I just cannot stress how much that resonated with me. Getting a good history, performing a thorough assessment and getting a good differential from those two things. And especially with these LVAD patients, how much harm we could do to someone who isn't in cardiac arrest that we do CPR to, but they're unresponsive because their sugar's 10. So I just wanted to mention that real quick. Cool. Ken, did you have anything?
I did, yes. I just wanted to ask about the future. What's the future of LVAD hold? It's becoming more and more common. Is this something that we're going to start seeing in a larger, more broad population of heart failure patients as this technology becomes more commonplace and safer? Is this something that's going to evolve to be a more routine thing, do you think?
Yeah, there have been great strides obviously made in the heart failure world, especially with the development of these continuous flow VADs and refining the VADs. Now we have, LVADs in terms of, the HeartMate 3, which is designed to even have a generated pulse to every 2 seconds or so to help prevent any stagnant blood from forming on the motor device itself. So people are really thinking about ways to make these better and more sustainable and try to prevent the complications that we're seeing. And as we start to get better at that, patients are going to be living longer with them. More patients are going to become candidates for them. More patients are going to be like, yeah, I can handle this. And we're going to see more and more of this, I think. I think the other thing to remind our EMS clinicians is that, we don't always have to go to the house to see a sick LVAD patient from a problem with their LVAD. Remember, we're putting these devices in patients to help them rehab and live a better quality of life and potentially get ready for a transplant. So you could, potentially get called to see one of these patients after, unfortunately, been struck by a vehicle when they were out walking to rehab, and we've seen this before. And we tend to see, obviously a larger number of these patients more concentrated around large academic centers, particularly transplant centers, that does this a lot. But you could see any of these patients anywhere throughout the country, right? And they don't just have to be having an LVAD-related issue. Like I said, they could be out for a walk one day because they're feeling good, because they have this device and everything's working, and they trip and fall, or they unfortunately get hit by a vehicle, or they're in a motor vehicle collision. And that's when you have to take all these things about into consideration, including the fact that they're anticoagulant.
Yeah, and that's where, it comes back to what you said before.
So I was just going to say that phrase reminds me of the phrase that, I was taught way back when I was a paramedic. Hey, kid, don't treat the monitor, treat the patient.
Yeah.
And that's exactly how it was said to me multiple times, I think. But, you got to consider everything and avoid tunnel vision and take a step back. Important thing to remember is, unless you think about it, you won't be worried about it, and you won't certainly diagnose it. So think about everything. Have a wide differential for these patients.
Awesome. Thank you so much. Ken, you want to finish this out?
Sure. Thank you, everybody, for listening to the Alert Medic 1 podcast. Thank you to our guest, Dr. Margolis. Thank you, Brian. Thank you, Moose. Please, if you enjoyed the show, subscribe to us on the podcast app of your choice. Leave us a rating and a review. Check us out on Facebook, Alert Medic 1, Twitter, alert_medic1, and, of course, our website, www.alertmedic1.com. We have lots of great content. We try to keep it updated as frequently as possible. Thank you, everybody, for listening. We couldn't do this without you, and have a good night.
You've been listening to the Alert Medic 1 podcast, the premier emergency medical services podcast with your hosts Mustafa Siddiq and Ken Sanner.